Hi, this is Jeff Spees, and welcome to the second of three planned conversations on issues around death and dying. We started this conversation with the Dean's Forum on November 15th at Trinity Cathedral with Dean Owens. The first session was on advanced care planning with some additional information on the effects of COVID-19. Today, we're going to be talking about suffering and some controversial options for end-of-life care. In the third section, we'll plan to scratch the surface of religion and spirituality at the end of life, and then hopefully have time for some Zoom conversations in which we can give and take and pick each other's brains. So but as I mentioned, the topic for today is suffering, and then going to some controversial end-of-life options. So the outline of my discussion will be suffering. What is it? How is it similar to and different from pain and other physical symptoms? What are the typical manifestations of suffering and the expectations of the sufferer? And how do we alleviate suffering? That's enough for us for multiple conversations and lectures, but we can I think, wrap up some concepts anyway. And the controversial end-of-life options that I'm going to be talking about include palliative sedation, conventional suicide, voluntarily stopping eating and drinking, medical aid in dying, and voluntary euthanasia. Okay, so suffering. Patients, as they're approaching worsening seriousness of their illness, especially the terminal stages, often say that what they dread most is not death, is not dying, but rather it is suffering. What is this suffering? Now, suffering can arise from physical symptoms, can be related to physical symptoms, and that's the way we most commonly think of it. But suffering in itself can be independent of physical symptoms, and some people who suffer the most have very little in the way of physical symptoms, and other people who have a great deal of pain and shortness of breath don't seem to be distressed by it much at all. Suffering, then, is essentially a human experience, as far as we know anyway. And it's difficult to define, but we know it when we experience it. Some 30 years ago, a remarkable book was published that really changed the thinking of a lot of people in medicine and in philosophy about suffering. This was written by Dr. Eric Cassell. It's been revised a couple of times since then. And Dr. Cassell pointed out that only a person can suffer, a whole person. Your bone can hurt, your liver can hurt, your heart can hurt, your lungs can feel short of breath. But a bone, a liver, a heart, a lung cannot suffer, because suffering encounters the meaning of what is being experienced. I've often used the example, so just imagine two women in adjacent beds, hospital ward, intensive care unit, emergency room, whatever setting. Both of these women have distended abdomens. Both of these women are having intermittent episodes of agonizing pain. They rate us 10 out of 10. And when it occurs, it comes in spasms and they scream out, "Please, dear God, make it stop." One of these women has ovarian cancer that has spread throughout her abdomen. With that has caused a high-grade partial bowel obstruction, so that with every little bubble of gas that moves through, she gets intense cramping abdominal pain that is agonizing. The other woman is giving birth to her first child. The pain is the same. The experience is totally different. The meaning is profoundly different. With each cramp, the woman with cancer knows that she is dying and that this is her life now. The woman giving birth knows that each pain gets her closer to holding her newborn infant. So the pain is the same, the suffering is profoundly different, and certainly the approach to the suffering, the experience, is profoundly different. The other point Dr. Cassell made about suffering is that suffering has a forward-looking focus, and it involves fear, the fear of being overcome. If this keeps up, I will not be able to endure it. I can't stand this anymore. Well, at the moment you are saying that, you are enduring it. You are standing it. So it is the anticipation of disaster that is what causes the suffering. In Dr. Cassell's words, he said that suffering is engendered when there is a threat to the integrity of the individual. And it continues until that threat is removed or the integrity is ensured. Okay. So that's what I think about, and I think is the best definition of suffering. So when someone is suffering, what do we expect from them? It's interesting that as a population, we are intrigued by, but also turn from suffering. If we go by an awful car accident on the highway where there's the squad and you see people crying and a patient being loaded into the ambulance, we're intrigued by that. We're rubberneckers. We're right there watching it. But if that keeps up, as in, for example, when we're watching television and one of those commercials comes on for the ASPCA or St. Jude's Children's Hospital that shows suffering children or suffering dogs over and over and over again, that repels us. We don't want to watch that. Some people, it has been postulated that as we observe someone who is dying and say that was a death with dignity, they maintained their dignity till the end, what we're really observing is that they're not showing their distress. That from the observer's standpoint, a dignified ending is an ending without observable suffering. Alphonse Daudet was an author in France in the last half of the 19th century, and he kept a journal when he was in a sanatorium and institution dealing with his disease. His disease was tertiary syphilis that caused a great deal of neuropathic pain. He kept a journal of this, and his words were assembled and published 20 years ago in this remarkable little book called In the Land of Pain. And Monsieur Daudet said that pain is always new to the sufferer, but loses its originality for those around him. That pain is fresh and intense. It's intense today as it was yesterday, and it's as fresh and present today as it was yesterday for the person who is going through it. But for the observers, it is, can you get over it already? I don't want to hear this anymore. The tradition, the Christian, and by tradition, what I mean is what is the Judeo-Christian tradition that we, at least as Episcopalians, inherit. Gives rise to the idea that there is a redemptive nature of suffering, that going through suffering leads to personal growth, leads to spiritual wholeness and healing, and that can certainly happen. The scriptures, the Hebrew and Christian scriptures, are full of expressions of people requesting relief from their suffering, from their distress, and these requests are directed to God. And these go from Moses to Elijah, through Job, through the psalmist, to some of the prophets, to the poignant time of Jesus in the Garden of Gethsemane. But there are fewer examples of what suffering looks like, or perhaps should look like, from the standpoint of the observer. And this is different. This is a different image. In Isaiah 53, the prophet is describing the suffering servant of the Messiah and says he was oppressed and he was afflicted, yet he did not open his mouth. Like a lamb that is led to the slaughter, and like a sheep that is before its shearers is silent, so he did not open his mouth. So this epitome of the servant of God suffers in silence, suffers without showing suffering. The Book of Common Prayer doesn't offer us a lot, but there is one prayer that I'd like to read. This is for on page 461 of the BCP, and this is in a list of prayers for use by sick persons. And for a sick person in pain, this is what it says. Lord Jesus Christ, by your patience in suffering, you hallowed earthly pain and gave us the example of obedience to your Father's will. Be near me in my time of weakness and pain. Sustain me by your grace, that my strength and courage may not fail. Heal me according to your will, and help me always to believe that what happens here is of little account if you hold me in eternal life, my Lord and my God. Amen. So that prayer suggests that the petitioner is asking for meaning, asking for healing of the suffering, perhaps, the meaning to be found in Jesus' suffering, or in saying, well, it's not so bad compared with the glory that will happen later. But it suggests that by finding that meaning, we'll be able to maintain that stiff upper lip and that hold on to our faith, and that showing the suffering may not be the ideal. I'm suspicious that these thoughts that are my thoughts may engender some pushback, and I'll look forward to hearing from you about that. Okay, how does one measure suffering? Well, in hospice and palliative care research, this has been a difficult prospect. In fact, to this point, nobody's been able to come up with a tool to measure suffering, although there have been some proposed. Usually the best that can happen are either what are called multi-symptom inventories in which a person rates their pain, their shortness of breath, their nausea, their appetite, their energy, their anxiety, their depressive feelings, their bowel function, all on each one on a 1 to 10 scale to get a composite score that is compared from day to day. And that's useful in the institutional or hospital setting in assessing how interventions are helping symptoms or not helping symptoms. But again, it's just a composite of symptoms. Another approach has been the idea of using quality of life measures, in which, again, different questions are asked, each one thought to have something to do with what quality of life would look like, and then coming up with some quality of life score. But neither of these gets at the issue of suffering. They might indirectly imply something that when someone feels less distressed, they might rate their symptoms as better because they feel more energy to deal with them. It might be just the opposite. But there's really been no tool developed to measure suffering. And the only one who can assess suffering, of course, is the person who is enduring it. And even in that situation, it's difficult. I've had innumerable patients who have just said, well, maybe I'm making too much of this. Everybody tells me that, you know, it's okay, it's okay, it can't be that bad, or they want me to think differently about it. I believe that that's not that. Well, here's the statement that I made, and this is a quote from my book. When a dying patient is told to try not to talk about it or to look on the bright side, it adds yet another layer to the suffering, that of loneliness. Because by implying to a person who is going through a distressing time that they need to look on the bright side, what you're really saying is, I don't want to hear about that anymore. You just can keep that to yourself. So how do we alleviate suffering? So from the professional standpoint, there are lots of approaches that are tried, but all of them really are designed to give people the space and the opportunity and the ability to find their own healing. Palliation of physical symptoms, of course, because it's impossible to deal with your inner pain if your bodily pain is wrenching all the time. Spiritual and psychological counseling, family counseling, healing of relationships, dignity therapy, which often involves legacy work or finding meaning or a message to give to those who you will leave behind. Expressive therapies, art and music therapy can be quite healing. The etc. includes all kinds of things like relaxation techniques and energy therapies, and they're all good and they all help. But they all do the same thing, and that is to get the person to the point of being able to find their own healing. Perhaps, yes, a good and insightful counselor can provide probing questions in which to generate insight, but is really up to the sufferer themselves to find the healing. What can one do as a friend, as a stop-byer, as a caregiver? Well, the first is to be present. There's a wonderful little snippet in the book of Job. Remember, in the book of Job, Job starts out as a rich man. He loses everything that he has. And then he is, including his family, except for his wife. And then he is afflicted physically with sores all over his body, and is sitting out by an ash heap because he can throw ashes on himself and it alleviates the pain and the itching from these sores. And then what happens is 3 of his buddies come up and stop by and to provide comfort. And there's an intriguing piece. Now, when Job's 3 friends heard of these troubles, they met together to go and console and comfort him. When they saw him from a distance, they did not recognize him, and they raised their voices and wept aloud, and they tore their robes and threw dust in the air upon their heads. They sat with him on the ground 7 days and 7 nights, and no one spoke a word to him, for they saw that his suffering was very great. Job's friends in those 2 verses did exactly the right thing. They were present with the sufferer. They were quiet. They presumably listened, at least allowed Job the chance to talk. Tearing their clothes and throwing ashes on themselves is a way of sharing the suffering. Compassion means to bear the suffering with, or to bear the pain with, to suffer with, to be with. Because suffering that is shared is suffering that is eased. It is only when Job's friends start talking and start giving advice that they screw up. The answer of what to do is, there's a great bumper sticker quote, although I haven't seen it in ages, but because it wouldn't mean anything if you didn't know the context. But the bumper sticker message of what to do as you are present with someone who is suffering is, don't just do something, sit there. Sit there and listen. That's the best you can do. So all of these things, these professional things, all of these interventions take time and they take energy. And that is just what most people at the very end of their lives don't have. They don't have time. They can see the time running out, and they don't have energy. Now, sometimes people are undergoing very difficult experiences, either physical symptoms or internal suffering. And they want and need relief and just don't have the possibility of encountering the healing that needs to happen to provide, that could potentially happen, relieve this. So what options are available to achieve relief from that which is unbearable? And what we're going to transition to are these end-of-life options that I'm going to call controversial, that are interventions that are designed to either lessen the awareness of or shorten the duration of the suffering. And the options that we're going to talk about include palliative sedation, killing oneself, voluntarily stopping eating and drinking, medical aid in dying, and voluntary euthanasia. Those are the what I'm calling the controversial options at the end of life. So why are they controversial? There's lots of issues, but basically one thing they all have in common is, at least as far as the controversy, I almost said controversy. I've been watching too many British mysteries lately. That is the issue of the possibility that these interventions might or do hasten death. And is hastening death a moral act? And this has been a question that has divided ethicists and religious leaders. Is it moral or ethical to engage in a practice designed to relieve suffering that either might or does hasten death? Okay, so why do people choose these these things, these options? Well, one is intractable symptoms and or unbearable suffering. The fear that these symptoms or suffering will get worse. The fear of loss of control or autonomy, and the fear of loss of dignity. Now, you'll see that this goes very similar to the reasons for suffering, is the description of suffering, that they might be related to symptoms, but that a lot of the concern, a lot of the reasons that people choose some of these options is worry or fear of what will happen next. Okay. So let's go and talk briefly about palliative sedation. This is a reasonably commonly employed practice. Palliative sedation is the use of sedating medications to relieve those intractable symptoms or unbearable suffering by reduction in patient consciousness. A lot of the medicines we use in palliative care and hospice do cause sleepiness as a side effect, either temporarily or on an ongoing basis. The most typical, most example are the pain medicines, the opioid pain medicines. Morphine makes people sleepy. It just does. But this is different. We're not talking about using drugs that might have a sedating effect. We're using drugs for relief of a symptom, and we know that that drug might have a sedating effect. What we are doing here is using the sedating effect of medications to relieve the symptoms. And the point is, the assumption is that a person who is asleep is unaware of the symptoms or distress that is happening. And since suffering is happening in the mind and the heart, if awareness is relieved, if awareness or alertness is removed, then the assumption is that the suffering is relieved. I've had there are arguments out there that say, but we don't know that. And people have done EEG studies to see, do the patients really experience symptoms while they're asleep? But as best as we can know, when one is asleep, one doesn't experience suffering. And this is probably best exemplified by the idea of getting a good night's sleep. This is something we talk about all the time. You'll feel better in the morning, or I need to sleep on this. Because the rejuvenation that happens in sleep, that one is not aware of what is going on. One is not aware of the pain. And there's some healing, some resetting that happens in sleep, so that we believe that we're right, that sedation, palliative sedation, does relieve suffering and probably makes physical symptoms that might be ongoing irrelevant, because the person is not experiencing them, even though the body may be. And this leads to the concept of temporary or respite sedation, which isn't done very often, but it is done sometimes. And the idea of temporary or respite sedation is put somebody to sleep. Someone wants to go to sleep for a couple of days to perhaps get a good night's sleep and reset. Maybe things will feel better because they'll have more energy to deal with what they're going through. Or the other time that this is used is when I would, for example, want to start a new medication that I think will be helpful, but might take a couple of days to kick in. But the person is in extreme distress now, so why don't we go to sleep for a couple days, take a nap for a couple days, do whatever procedure needs to be done, or to start whatever medication, allow it to build up in the bloodstream, and then wake up again and see if you feel better. So this is not really all that controversial, although it isn't really done all that much, at least as a formal procedure. What's more commonly thought of when one thinks of palliative sedation is continuous sedation until death. And this needs to be limited to patients with a short survival prognosis, measured in days, not weeks. The 14 days is an arbitrary level, but most of the time, prognosis is much less than that, in which the sedating medicines are fairly rapidly titrated to the level of sedation desired by the patient, which is usually enough so that they're not experiencing the distress that occurs. I like to try and aim for someone who is arousable with significant, you can shake them so that they can recognize that you're there. But again, it's variable depending on what their goal is, how sleepy they need to be. Now, during this time, they will have much less ability to communicate with those around them. And this is one reason that this is a little controversial, a little distressing, because if there's a family member from out of town who hasn't been there to say their goodbyes, that can be an issue. The piece that generates more controversy, though, is that during this time, the person will not be able to eat or drink substantially anyway. Now, the practicalities are that people who are at this point in their dying trajectory already are rarely eating much of anything and rarely drinking much of anything or taking just little sips. We know as best as we can determine that the anorexia, the loss of appetite that happens, means that hunger just doesn't become much of an issue. And even in someone who is healthy and undergoes a hunger strike, they lose their sense of hunger in 2-3 days. The sense of thirst persists and really can be helped with mouth moistening, but it is an ongoing thing. But again, presumably the sedation would alleviate the sensations. So this is what palliative sedation is, the idea of going to sleep. Now, okay. So is this an ethical intervention? Well, the ethical construct that is most cited in evaluating or in defending palliative sedation as an intervention comes from Thomas Aquinas back in the 13th century. And Aquinas posited that an action that has 2 foreseeable outcomes, and the action that we're talking about here is palliative sedation. It has 2 foreseeable outcomes. One desired outcome, which is relief of the suffering, and the other undesired outcome, hastening death, can be moral if 4 criteria are met. The first is that the action itself is morally positive or neutral, and giving a medicine to a person is a morally neutral act. That the desired and not the undesired effect is intended. This is key, that the intention of the sedation is relief of the suffering and not hastening death. And this can be a challenge sometimes when the patient is fairly sedated and looks comfortable, but the family's really distressed because they're still alive and want things turned up. And that can be the ethical challenge, because I have to remember that the patient is my patient. The family is my concern, but not my primary patient. The third criteria that Aquinas posited is that the desired effect is not achieved by the undesired effect. In fact, so the idea is that if I kill them and that's what causes them to be relieved of their suffering, that is not a moral act under Aquinas's principle of double effect. and that there's a proportionality between the desired and undesired effects. That if one believes that relief of unbearable suffering is morally on a par with the loss of a couple of days of life, then that can make the palliative sedation a moral act. Okay. The Supreme Court of the United States in 1997 took Aquinas' argument in a legal statute. This was the case of Vacco v. Quill in 1997. The Supreme Court found no right to die in the Constitution. But the Supreme Court recognized that aggressive palliative care that relieved symptoms as its intent was licit, even if it risked death, as long as the intent was alleviation of pain and suffering. Now, intent is tough to prove, but the Supreme Court held that Aquinas' thinking at least made some sense as far as constitutional law in the United States. That it was okay to use aggressive sedating medications if the intent was to relieve symptoms, and that they effectively did that, as long as that was the intent, even if with the known side effect that death might be hastened. Okay, so those are the ethical moral arguments that are used, but the answer actually turns out to be a whole lot easier, because some fairly recent data show that, at least in general, there's no evidence that palliative sedation in these appropriate patients shortens survival at all. It's tough to know from patient to patient. I've certainly had people in whom they, shortly after their sedation, they died, and it was a bit of a surprise. And I've certainly had people who became sedated and lived for longer than we thought. But people die sooner or live longer all the time than what I think is going to happen. But it appears that palliative sedation does not shorten life, and therefore should be considered a moral and ethical act and available for appropriate patients. Okay. But if we remember the reasons that people approach these controversial options, and this is the same list that was a few slides ago: intractable symptoms or unbearable suffering, and then the fear of worsening symptoms or suffering, of loss of control or autonomy, and the loss of dignity. For a lot of these situations, palliative sedation is not at least palliative sedation until death is not a viable option, because that's only an option, an ethical and moral option, at the very end of life. So what does one do if the concern is, well, I'm not imminently dying, but I'm in distress and I'm afraid it's going to get worse and I won't be able to bear it? Considerations have been given to voluntarily shortening life. The idea being that if I live a shorter duration, I will suffer for a shorter duration. Or if my life is ended when my suffering is at the most I can stand, and it only looks like it will get worse from here, if I can end my life at that point, I can avoid future suffering or in what I consider an intolerable situation. Okay, so this is the idea of shortening life as a means of lessening suffering. And what people have done for millennia is kill themselves. I'm going to mention conventional suicide, shooting oneself, gassing with the car, jumping off a bridge, things like that. They are effective, and they always, and suicide, I believe, is usually done to relieve suffering. There is a distress in the mind and heart of the individual that cannot be resolved. But conventional suicide is usually performed alone and in secret. And this is antithetical to the good death, the dignified ending that most people desire in general. In the hospice world, there is something that is talked about a lot, and this is voluntarily stopping eating and drinking. Now, is that different than jumping off a bridge? Well, I guess qualitatively it's not. But the death happens at some future time. And this has been argued that food and water are not inherent to the person. There are things that person takes in, and if that person chooses to not take them in, that is that person's right. Now, voluntarily stopping eating and drinking does happen. The statistics suggest that it doesn't happen very often, and we can talk about why that might be if you would like. But it's sometimes seen as a reasonable option because, as I mentioned, loss of appetite is very common with terminal illness. I mentioned the hunger and thirst issues, that hunger tends to go away. And if you already have anorexia, which is loss of appetite, then hunger is really not such a big deal. Thirst is an issue, can be helped by mouth moisture, but not totally alleviated. The big thing about voluntarily stopping eating and drinking is that it usually takes longer than you think it might. This is one thing that we assume that we have to keep eating and drinking because that's what we do, and we get hungry and we assume that means something bad is happening. In a study that was really a survey of nurses who were asked to recall their patients who had done this, had ended their lives while they were not eating and drinking by choice. The average time to death was about 15 days in that study. We had one patient in our inpatient hospice unit at Ames Family Hospice House who went through this. And this was basically a young, otherwise healthy man in a persistent comatose state whose mother finally came to the decision that he would not want to be maintained with this tube feeding. And his body lived for 6 weeks before he died. So voluntarily stopping eating and drinking is an option that's often talked about, not often employed. Okay, medical aid in dying. This is probably the big print controversial option in the United States now. This had previously been called physician-assisted suicide and lots of other euphemisms, but I think medical aid in dying has become the most accepted term, at least by its proponents and in an analysis. Now, I would point that suicide is legal throughout the United States. That hasn't always been the case, but assisting a suicide is not legal. Assisting suicide is homicide in every state, except in these particular situations. Medical aid in dying, and we'll go through exactly what this involves. Medical aid in dying basically is a physician providing a lethal prescription to a patient for medications that, when taken, will cause the patient's death. That's medical aid in dying. It's currently legal in 9 states in the United States, and these are the 9 MAID states right now. Also in the District of Columbia and throughout Canada, other places in Europe, but 9 states that once California joined this list, then it got the people in the hospice and palliative care world's attention more profoundly, because this now means that nearly 1 in 5 or 1 in 6 Americans lives in a state in which medical aid in dying is a legal option. Now, the state of Oregon has the longest experience, and I'm going to go through the Oregon statute and experience in a little detail, because that really shows what medical aid in dying, how it happens. Because every other state has modeled their statutes on the Oregon statute. Some of them are a little different, but the basic model is the same. Now, the Oregon Death with Dignity Act applies to an Oregon resident who is at least 18 years of age, who is able to make and communicate their own decisions, and who has a terminal illness. And as we mentioned in the previous session, terminal illness in the United States generally means a survival prognosis of 6 months or less. So this is the population that can take advantage of the Oregon Death with Dignity Act. You have to be a resident, a legal resident of the state of Oregon. And you have to, with a terminal illness, and you have to be able to make and communicate your own decisions. Once more, you have to be able to swallow the fatal dose, or if you have a feeding tube, you have to be able to physically inject the fatal dose into your feeding tube. No one else is allowed to do that for you, or to administer the dose to you. You have to be able to do it yourself. Someone else can dissolve the pills in the solution so that you can, drink it. And they can even hold the cup for you, but you have to be able to swallow it, or you have to be able to physically push the plunger to administer the dose into your feeding tube. In order to qualify for the prescription, you have to verbally request assisted dying from your physician twice, and these 2 requests have to be separated by at least 15 days. And you also have to provide a signed and witnessed written request, so that this is how you communicate your wishes. Sometime during this time, usually it happens in that 15-day interim, you must consult with a second physician whose job is to confirm the terminal state and to confirm your decision-making capacity. If either of these 2 physicians feel that depression or mental illness is what is causing you to make this request, a psychiatry consultation becomes mandatory. The other thing that I should note, that this doesn't happen very often, but it does happen occasionally. And physician reporting is mandatory, so that there's good data. You're not, the doctor suffers no adverse consequences from reporting what happens. And in fact, it's actually a safeguard in the system. So this leads to there is good data for the last 23 years from the state of Oregon. Okay, so from 1997 through 2019, 1,657 residents of the state of Oregon died from a lethal dose of medication. And this represents about 0.5% of all the people who died in Oregon during that same 23 year period of time. Most common underlying terminal diagnosis has been cancer. And this makes sense. People with cancer these are the prototypes of patients that are put out there as the example of why one wants to make medical aid in dying legal, the cancer patient with unbearable pain and physical symptoms. And the other point about cancer, patients with cancer, is that they can see the end coming. When the chemotherapy is no longer working, when the conversations have happened, that the cancer is now in a terminal state. Sometimes this causes people to then think about, well, maybe I'm done. I don't know. It is interesting, given the fact that the reasons for people looking at medical aid in dying and these other controversial options is fear of what will happen, is that neurologic diseases tend to be disproportionately represented. Amyotrophic lateral sclerosis, Lou Gehrig's disease, this horrible, debilitating neuromuscular disease in which a body loses its ability to move and function, but the brain stays smart. Stephen Hawking was the classic example, although he had a very protracted course with his ALS. These patients with these kinds of neurologic disorders, or Brittany Maynard, who some of you may remember from several years ago, who made a public act of her aided death. Brittany had a brain tumor. So because of the fear of what will happen in a situation that will become intolerable causes people to seek out medical aid in dying. During this time, there has been no evidence of a slippery slope. This has been one of the arguments against medical aid in dying, is, well, if we open up this right, this ability for this group of patients, then others will get on the bandwagon, or everybody will want to do it. This hasn't happened. This 0.5% incidence, 0.5% of deaths in Oregon resulting from medical aid in dying has been remarkably consistent over these past 22, 23 years. One thing that has happened is the cost has gone up. Secobarbital was the drug of choice when throughout most of the history of this, but secobarbital, of course, then the cost went up as many pharmaceutical companies stopped making secobarbital or pentobarbital, the drug that has become less available because it has been used in capital punishment in this country. These drugs have become less available, and then the companies that made them made the price go up. For a period of time in the early 2000s, the cost of a fatal dose of secobarbital went from about $300 to over $2,500. And this drug is not a therapeutic formulary drug, so most insurance plans do not consider medical aid in dying a therapeutic event, and so the drugs don't get covered. So the increased costs, and really now the lack of availability, have caused doctors to come up with new cocktails of drugs that remain to be effective, but has caused just some shuffling in the medical practice. Okay. In the state of Ohio, as I mentioned, medical aid in dying is not legal, and the current legislature and governor are not favorable to it. The population is split, as it is in a lot of states. For those who are interested in further information and considering advocacy, I'm just providing the information if you like. The Ohio End of Life Options group is an active force in the state of Ohio. The link to to their website is available in the handout. Okay, so that's medical aid in dying. Now, this is limited because you have to be able to be of sound mind. You have to live in one of the states that makes it legal. You can't just, there's no tourist medical aid in dying. Brittany Maynard moved when she knew that she had her brain tumor and she would probably want to avail herself at some point of medical aid in dying. She moved from California, where it was not legal at the time, to Oregon several months before the time came that she died. Okay. Anyway, so sorry I went down a road there, but the being of sound mind and being able to request it, and that has to be in real time. In none of these states is an advance directive requesting medical aid in dying valid. So this has to be requested when you are able to request it. Okay. Voluntary euthanasia. This is an active death caused by someone else administering usually a fatal drug. This is the example that's used is we put our dogs to sleep, and that's what euthanasia is. The word voluntary is used because it's presumed that the euthanasia in this situation is presumed to be requested by the patient. I would note that voluntary euthanasia, I'll get on a soapbox here, voluntary euthanasia is not legal anywhere in the United States, but involuntary euthanasia is. We call it capital punishment. Okay, off the soapbox. So voluntary euthanasia is not available, not legal anywhere in the United States. It is practiced in a few European nations. The Netherlands has the most experience, and there are some good data as to how that happens in the Netherlands. But it's not available and is only open in all of these nations to citizens. Now, Switzerland does allow medical aid in dying, and I believe voluntary euthanasia for non-citizens. And there is a trickle of a tourist dying thing that happens in Switzerland. But again, it's not cheap, and then you end up not at home. And often not with the people that you love around you, because they all got to get to Switzerland. Okay. So that's really what I had to say today. To review, suffering can derive from physical symptoms, but in and of itself, suffering is related to the meaning of the symptoms and the meaning of the experience that one is going through. That alleviation of suffering requires acknowledging it, affirming its presence, and empathy if you want to help someone else. But that a dying person might experience intolerable distress that they neither have the time nor energy to deal with. But that for someone enduring unendurable suffering near the end of their life, aggressive but at various levels controversial options exist. Palliative sedation for patients in the last days of their life is legal and can be appropriate. Medical aid in dying is variably available and involves strict eligibility and procedures. These are the bottom line points here. So where do we go next in this course? Well, the third session, we will deal with religion and spirituality at the end of life. And I would hope that I've piqued enough interest in any or all of the topics we've dealt with in which we can have some Zoom discussion sessions. I've mentioned a couple of times that if you have questions that you would like to be sure are addressed in any Zoom session, consider emailing them to me. The link is on your handouts, and I can make sure that we tailor the Zoom sessions to those questions. it's not a mandatory thing. Give and take is wonderful and preferred, but there are some things that I am perhaps not an expert in and I might need to do some homework on. So again, look forward to seeing you in the next session and talking with you soon. Be at peace.